He has been head of the Department of Orthopedics in Medical College Agra, and he has trained many orthopedic surgeons who are now heading the departments in different parts of the country. He has presented many papers in the conferences and has organized many national conferences also, and is playing active part in today's conference also.
Respected Dr. Sandhu Saab, Dr. Sadiq ji, my mentor, Professor K.P. Srivastava. I'm thankful to IOA for giving me this opportunity to talk on this subject as a conference lecture. I'll be speaking on the current concepts of the management of trochanteric fractures. Friends, this fracture is a problem for all of us simply because the impact of this injury is nasty. The latest reports say that 17% die within 6 months, 25% have a reduction in their life expectancy, and 50% have a deficit in their activity of daily living. We must do better. This is a challenge for us. We must do better. The predictors for the hip fractures outcome are pre-injury physical and cognitive status, the ability to visit friends and go for shopping, presence of home companions, post-operative ambulations, and post-operative complications. And out of these predictors, surgeon has a control on the last two, and that is the post-operative ambulations and the post-operative complications. The pre-operative management needs a little change now. One has to tune up the correctable comorbidities. These patients have to be operated early. That means the surgery is urgent, but is not an emergency surgery. Maintain the extremity in position of comfort. The various RCTs have clearly mentioned that the preoperative buccal traction is of no value now. General versus spinal anesthesia, this hardly matters. Both have the similar outcome. This has been well proven by the literature. First and the foremost thing that we require is a plain X-ray AP view, preferably in a neutral position or internal rotation, and a cross-table lateral view. What helps us to decide about the planning is a traction view. If possible, this traction view will give you more informations regarding the management. The factors which influence the construct of the strength, you all are aware of these factors. The uncontrolled factors include the fracture geometry and the bone quality, and the fractures and the factors that can be controlled are the quality of reduction, the implant placement, and the selection of the implants. Friends, the stability is the ability of the reduced fractures to support the physiological loading. And when implant is added to it, implant supports the bone and the bone supports the implant. Both are essential. In the fracture stability relates not only to the number of the fragments the trochanteric fracture has, but it also relates to the plane of the fracture. If you see, the importance is of posterior medial part. If it is intact, it makes the stability after reduction, and when it's broken, it converts a fracture into an unstable one. The plane of fracture, when it is too fragmentary, it makes your job simpler. But when the lesser trochanter gets involved, then it becomes an unstable fracture. The number of fragments increases. The number of fragments they increase, the instability increases. And lastly, even with there is no number of increase in the number of the segments, but this line converts this into an unstable fracture. Though it is two fragmentary, you call it a reverse oblique fracture. And this is a very common classification being used by most of us in the stable and the unstable varieties. Now, what's important about this is in the stable regions, stable fractures, the location of the lesser trochanter, whether this lesser trochanter is with the proximal segment or is with the distal segment. That is a clue for creating problems in reduction and overcoming those problems of the reduction. The rest you all know. Here the posteromedial has gone, and this is one which is grossly unstable. So we have a stability and instability as far as this classification goes. The importance is of the posteromedial segment. These are the varieties of the unstable fractures. Posteromedial segment is involved. There is a reverse obliquity, and there is a subtrochanteric extensions, and the new one which has been added to it is the transtrochanteric fractures. Now, coming to the bone quality, a younger person has a dense cancellous bone throughout the proximal femur, but in an elderly person there is not the marked loss of the trabeculae. So what's important is we must place our implants where the remaining trabeculae resides. That is very important. Now, in these poor quality of bone, should we strengthen the bone implant interface? The literature has a difference of opinions, and the polymethyl methacrate, it has 12 to 37% increase in the load to failure. CPCC has 15% increased yield strength. The clinical factors in 2010 influence the delivery, the cost, and the complications must be considered. Hydroxyapatite has also its role to play, but my dear friends, all these studies are experimental ones. No one has shown improvement in the clinical outcome or the cost of the effectiveness. So whether you have to strengthen by using all these things is still, there is no good clinical report available in the literature. So we come to the factors which can be controlled by the surgeon. The quality of reduction, quality implant placement, and the implant selection. We can do something better with all these three things which are in our control, and that is the aim of the treatment. When I'm going for the reductions, the literature reveals that there is no role of displacement osteotomies that we were using in late 90s. Limited role of reduction and fixation of the trochanteric fragments. Whether you fix those loose trochanteric fragments or not, that has very limited role. Here comes the biology versus the stability. So the surgical goal is a biplanar anatomic alignment of the proximal and the shaft fragments. You all know the reduction in an unstable fracture is a bit difficult. The close reduction is preferable, but that is not the rule of the thumb. In case you are not able to achieve it for many reasons, an open reduction is required, and this open reduction should be biologically respectful manner. Kindly note, the open reduction should be in a biologically respectful manner. There are various methods to achieve this reduction by closed or the open means. You can have a joystick. Now this joystick technique has been used by us for the last 15 years. The traction will not reduce this sag, but a lever into the fracture will do it, and same has been proved by the literature in 2007. We can use a bone hook to reduce it. We can use a Hoffman's retractor to reduce it. And once we are going for an open one, a reduction clamp is an ideal solution for such nasty fractures. Now, if you can see, appreciate this, after reduction, you find a sagging. And this sagging cannot be corrected by traction alone. So what you need is a posterior reduction support, which is available in the form of POD, device for posterior reduction. Now if you can appreciate, this is when there is a sagging, and after the sagging has been corrected by the posterior device. These posterior devices can be very easily attached to your table and serve you in a much better way. You need not to ask your assistants to keep on uplifting the proximal segment. So this is the fracture reduction which requires. Now here what is important to learn is a double density shadow that you see. This double density shadow means your fracture in a lateral view shows intersusception. You must be aware of this double density which you see in your image pictures when you go for reductions. This is of an utmost importance. And kindly appreciate the double density here, and after using a joystick, see the double density disappears. That is an ideal reduction. Another important point is the tip apex index tag, which is very commonly known. The placement has to be in the dead center. Is defined as the point where a line parallel to and in the middle of the femoral neck which intersects the joint. This is a well-known article by Baumgartner, and here he speaks that minimum of 24 mm is allowed, both in the AP and the lateral view. Beyond this, the chances of cutout are increasing every time. So the optimal screw placement has to be dead center and very deep. TED has to be below 25 mm in all the respects, because this is the place where you have a best bone, no moment arm for the rotational instability, maximum slide, and it validates reduction. When you are using the proximal femoral nails, you must be very careful while placing them. All these three tips should be at the similar level. If you do not maintain this, you are likely to have ZFX. So, intramedullary versus plate fixation, what's the big deal? Let's see what the literature says. Intramedullary fixation is a percutaneous procedure. There is a limited loss of blood, limited muscle stripping, complications and rehabilitation times are reduced. This is the first generation proximal femoral nail known by the name of the gamma nail, and the studies which was done clinically, according to many of the authors, the complications were higher than the advantages, to the extent that iron fixation may be superior for intertrochanteric and subtrochanteric extension and reverse oblique fractures. CHS is a forgiving implant when used by inexperienced surgeon. The gamma nail is not. That is what was the conclusion by the literature. But friends, an article in 2009 by Bhandari and Schmitz says that our meta-analysis of the randomized trial suggests that the previous concerns about the increased femoral shaft fracture risk with the gamma nail have been resolved with improved implant design and improved learning curves. So the earlier meta-analysis and randomized trials should be interpreted with caution in light of the more recent evidences. So no more increased risk with the nails is now. Another clinical RCT, the RCTs say there is no difference for the stable fractures what kind of implant you are using. Faster and less bloody for the unstable fractures, fewer intramedullary complications than the gamma nails, but the weaknesses are there is no stratification of the unstable fractures, there are learning curve issues, and no anatomic outcomes, but wide functional outcomes are there. Again, the clinical trials reveal that there is longer surgery, less blood loss, improved post-operative mobility, improved community ambulations, and 45% less sliding, so the limb length discrepancies are reduced with the intramedullary fixation than with the extramedullary ones. This all you know, the intramedullary one reduces the lever arm, so it's better. Now the key point here is, it is not the reduced lever arm alone that offers the clinical significant mechanical advantages, but rather the intramedullary buttress that the nail provides to resist the excessive fracture collapse. So the reduced collapse has been demonstrated in most of the randomized studies that have been looked at the variables. The proximal femoral nails substitute for the incompetent posterior medial cortex. You see, posterior medial cortex is reformed without causing any varus defect. It compensates both for the medial as well as for the lateral defects. The famous article by Palm et al. In 2007 talks about the complications of the extramedullary fixations, the iatrogenic intraoperative lateral wall fractures, 31% risk in A2 fractures, 22% failure rate, and overall 3% overall failure rates. The selected clinical trials for the intramedullary fixations, they reveal that there is less sliding and less shaft medialization. There is a minimum change in the neck shaft angle of 5 degrees within 6 weeks. The shaft medialization is also low. And there is a improved post-operative mobility within 4 months, less sliding and less shaft medialization. These are the various reports available in the literature. Trochanteric stabilization plate was introduced to strengthen the extramedullary fixation. It decreases the collapse, increases the operative time and the blood loss, and increases the complications in terms of length of rehabilitation. Overall, the potential advantages of trochanteric stabilization plates have been limits amount of fracture collapse, allows screw fixation of the greater trochanter, but the potential disadvantages are that may compromise fracture union. Trochanteric bursitis is one of the common complications and it requires additional exposures and is expensive. The percutaneous compression plating, which has been introduced by Gottlieb, it has minimal operative trauma, no fracture exposure, immediate full weight bearing, prevents fracture collapse, provides rotational stability. These are the claims for this, but the studies reveal that although the orthopedic surgeons are advised to consider PCCP fixation, As an additional alternative treatment for the intertrochanteric fractures, high-quality randomized trials are still needed to assess the benefits of this minimally invasive procedure, and this is in 2012. The best indications for intramedullary fixations are the reverse oblique fractures and the intertrochanteric fractures with subtrochanteric extensions. The reverse oblique fractures, when compared, there is a poor implant position with DHS 80% failures, and with compression hip screws again there are 56% failures, 20% failures in other study, and in intramedullary fixation they have reported good response. Now this is the reverse oblique fracture treated by a DCS. Reverse oblique fractures, the advantages by the intramedullary nailing is open reduction, decreases the incidence of the open reduction, operative time, blood loss, failure rates, and major reoperations. This was a RCT in 2002. So the reverse oblique fractures, they do very well with intramedullary fixations. Another example for reverse oblique fractures, the trochanteric fractures with the subtrochanteric extension when treated with extramedullary devices, this is the outcome, and when it is done with intramedullary devices, the outcomes are relatively better. So the evidence-based bottom lines for 347 articles reviewed, 10 relevant and 5 RCTs, the evidence-based bottom lines are unacceptable for failure rates with CHS, better results with 95-degree devices, best results with intramedullary devices, best functional outcome is still not known. So with the stable fractures, there is no confusion, no doubt. You can go ahead with any kind of implant you prefer. DHS is recommended. In such a stable fracture with widely displaced, you can have a very good outcome with the extramedullary device like this. But there is no data to support the nailing over these slide plate fixations in A1 fractures. So the nails are for the subtrochanteric fractures and extensions. When we compare this study with the extensions, the patients have all ambulatory, no SA versus. They have excluded the subtrochanteric fractures here. Only 4 all experienced surgeons. This is the report, and the final outcome is skin to skin time is unchanged, fewer blood transfusions needed with intramedullary fixations, better walking ability in unstable fractures with intramedullary fixations, no shaft fractures, fewer reoperations needed in intramedullary fixation in comparison to the extramedullary devices. So the conclusions they point out is intramedullary fixation or CHS are good for stable fractures and unlocked intramedullary for the unstable fractures. So these are the reports. However, the grossly underpowered beta error is there. Any patient is eligible from 42 to 99. This was their study. Use a long nail. The outcome measures are pre-functional, perfunctionary. So this is the gold for the elderly persons. The arm hip screws, Tata supports use for unstable fractures, RCT for document improved anatomy and the early functions. Iatrogenic problems are decreased with current designs and techniques. The contraindications for intramedullary fixation. This is important to learn. Younger patients, there is an excess bone removal. Basal neck fractures, there have iatrogenic displacements. Stable fractures requiring open reductions, inefficient. Stable fractures with a very narrow medullary canal. These are the contraindications recommended. The technical tips for this procedure, it's important. While positioning the patient, the hip is adducted. The unobstructed AP and lateral imaging and the fracture is reduced. But what happens is, once we have adducted, The strong traction without well-led counter traction abducts the fractured hip. We are thinking that while doing adduction, while pulling this leg, not holding the other one, we feel the other way. So, adduction has to be there. Close procedure. While going through the reaming, you should be on the medial side, otherwise you will damage it. Entry point needs care, can be gradually enlarged with the pilot hole, and you must see that your pilot rack, when you go on the medial side, there is a compact bone, on the lateral side is a free bone, and if you are not comfortable with the trajectory, you will lateralize this one, and the lateralization will produce these results. So achieve a neck shaft angle of more than 130 degrees. Post-operative management allow all the patients with early weight bearing, allow them for self-regulation. Which nail design is best? Proximal diameter, nail length, distal interlocking, proximal screws, 1 or 2 needed. Nobody knows till now. They are still under trials.
Professor
The
Pruthi,
clinical
please,
significance, I'm just closing, sir.
please wind up.
Yes, sir. You all know about these problems. So, finally, I conclude that remember the Coffer's variables. Implant have a different traits, choose wisely. Position screws centrally and very deep. Healing is no longer a success. Deformity and functions matter. Perioperative insert counts. Thank you, sir. Thank you very much for your patient hearing.
Thank you very much, Dr. Pruthi, for an illustrative talk. Now we request another stalwart of our association, Professor N.S. Lord, who will be speaking on minimally invasive surgery for complex peripheral extremity trauma. Professor Lord, I think, is a known personality in this association, even to